Hello, dear friends. I hope you are okay. And we have been stopping for some while, but we are going now to recontinue our series of applied neuroanatomy, and we are going to start the sector of the blood supply of the neck and the brain by the anatomy of the internal carotid artery. Internal carotid artery is one of the two terminal branches and a direct continuation of the common carotid. The common carotid divides into internal carotid and external carotid arteries. We have two common carotid arteries that arise between C3, they divide between C3 and C5, so the origin of the internal carotid artery is between C3 and C5, usually at the upper border of the thyroid cartilage. There might be variations at the level of origin between the right and the left internal carotid arteries, and this is of importance if you are going to do carotid endarterectomy, as we'll see later. Internal carotid artery supplies most of the brain through dividing into anterior and middle cerebral arteries. So the main supply of the brain is from the internal carotid artery, and the internal carotid artery gives no branches in the neck. No branches from the internal carotid artery in the neck. Then it continues along the carotid sheath in the neck and enters in the skull through the carotid canal in the petrous bone. So this is a diagram showing the common carotid artery. Between C3 and C5, it divides into external and internal carotid arteries. Then the internal carotid artery enters the cranial cavity, enters the skull through a canal in the petrous bone called the carotid canal, passes in the cavernous sinus, and the terminal branches form the anterior cerebral and middle cerebral arteries. Anterior cerebral and middle cerebral arteries. We have two common carotid arteries. The left one arises directly from the aortic arch, and the right arises from the right innominate artery. So, this is the aortic arch. Aortic arch gives three branches: the left subclavian, the left common carotid, and the innominate artery, which divides into the right subclavian and the right common carotid, and you see that the vertebral arises from the second part of the subclavian. Another view, the left subclavian on its way to the arm, to the left arm, from the axillary artery, gives the vertebra, and the left common carotid, which will divide into internal and external carotids, and the innominate artery, which divides into the right common carotid and the right subclavian. This is a true angiography, a normal angiography, showing here the aortic arch. Here is the left subclavian, here is the left common carotid, and here is the innominate artery, dividing into the right subclavian and the right common carotid, and you see also the vertebral arising from the second part of the subclavian artery. Internal carotid artery recently is divided into 7 segments. I know there are several divisions dividing it into 3 segments, into 5 segments, and into 7 segments. The 7 segments are named according to the areas through which the artery passes. So we have the cervical segment, or C1, in the neck, the petrous segment, C2, in the petrous bone, the lacerum segment or laceral segments above the foramen lacerum, leaving the petrous bone, cavernous segment inside the cavernous sinus, the clinoid segment, medial to the anterior clinoid, as we will see, it is an extradural segment, and intracranially the ophthalmic segment and the communicating segment. And to remember the name, come please, let children consume our candy. Cervical, petrous, laceral, cavernous, clinoidal, ophthalmic, and communicating. This is a view of the internal carotid artery showing the different segments. So the first C1 is in the neck. C2 or the petrous part is in the petrous bone. The C3 or lateral segment is above the foramen lacerum on its way to the cavernous sinus. C4 is the cavernous part, and C5 is the clinoidal, which is a small segment medial to the anterior clinoid. Then intracranially we have the ophthalmic segment from the origin of the ophthalmic artery to the posterior communicating artery, and the last segment is the communicating segment from the posterior cerebral artery to the bifurcation of the carotid. Another view showing C1 cervical, C2 petrous, C3 laceral, C4 C2 petrous, C3 laceral, and C4 cavernous, C5 clinoidal, C6 ophthalmic, and C7 communicating. We start talking by each segment separately. Start by the cervical segment. Cervical segment is one of the two terminal branches and the direct continuation of the common carotid. So the internal carotid is the direct continuation of the common carotid, and the common carotid divides between C3 and C5 into internal and external carotids. It originates, as we said, between C3 and C5, C4, C5, upper border of the thyroid cartilage. The cervical segment of the internal carotid passes inside the carotid sheath with the internal jugular vein lateral to it and the vagus nerve in between, posterior sympathetic chain attached to the posterior surface of the sheath from outside. So there is a constant relation of the internal and the common carotid artery all through the neck. They are included, whether common or internal, in a carotid sheath with the internal jugular vein in the neck lateral to it, lateral to the carotid, with the vagus nerve in between and the more posterior plane, and the sympathetic chain embedded in the posterior surface of the carotid sheath, a constant relation all through the neck. As we said before, the internal carotid artery gives no branches in the neck. Then, close to its origin at the bifurcation of the common carotid, at the beginning of the internal carotid contains two structures. We have the carotid bulge or carotid bulb, two structures, carotid elevation or swelling, carotid swelling, here this swelling or bulb, containing what? Containing baroreceptors, detecting changes in the blood pressure, and the carotid body acting as a chemoreceptor, detecting changes in blood gases. So, as you will see, carotid artery is a very important artery because it is supplying the most important organ in the body. So it has a special protective mechanism God created at the entrance of the carotid artery, where, if you consider the carotid artery, the golden gate of the blood going to the brain. It has something called baroreceptors and the carotid body, which are present in an area called the carotid sinus or carotid bulb. Another continuation of the anatomy of the cervical segment. At the neck, the carotid artery is covered by the anterior border of the sternomastoid muscle. So you get to take the sternomastoid muscle laterally to expose the carotid. At the upper neck, it is crossed by the hypoglossal nerve deep to the posterior belly of digastric. So we have a nerve and the muscle. Anterior to it is the ansa cervicalis, formed of the descendens cervicalis from C2, C3, and descendens hypoglossi, also C2, C3, but coming with the hypoglossal nerve, forming a loop in front of the internal carotid artery in the neck. So, internal carotid artery in the neck is crossed from below upwards by the hypoglossal nerve and posterior belly of digastric below, and above by another nerve and the muscle, which is the glossopharyngeal nerve, the stylopharyngeus muscle, and the stylohyoid muscle. So, we'll repeat it again, but it is present anterior and not far from the vertebral artery. You can feel the carotid at the carotid tubercle, which is the transverse foramen transversarium of C6. If you took lateral transverse process, you can feel the carotid there. This is to know that the vertebral and the carotid artery are not far from each other. So again, carotid artery, we'll discuss it with the figures better. So this is the internal carotid artery forming the carotid sinus or the carotid bulb, containing the baroreceptors and the chemoreceptors. What are they used for? We said the golden gate. The baroreceptors are stretch receptors. They are responsible for the streaming of continuous blood flow along the internal carotid artery, and they are sensitive to stretch. When the blood pressure elevates, you get stretching of the carotid sinus, and then you get a parasympathetic activation of the parasympathetic drive, which is supplied by the glossopharyngeal nerve, and you get lowering of the blood pressure. On the contrary, when you get slow or low flow in the internal carotid artery, they recoil and there is no stretching, so there is no parasympathetic drive, so the sympathetic takes over and causes vasoconstriction of the blood vessels, but the carotid to maintain blood flow, constant blood flow in the brain. And this is very important in sudden changes in the position. For instance, you are sitting and you are standing up. When you stand up, you should get some decrease in the blood pressure, but because of the baroreceptors, you get some degree of slowing of the blood in the carotid, so that you get recoil of the carotid sinus and you get the sympathetic drive to maintain your blood pressure. The carotid body is a very small structure present also at the entrance of the internal carotid artery, and it is continuously measuring the blood gases, oxygen, carbon dioxide. If there is any decrease in oxygen, any decrease in the oxygenated blood going to the brain, it will stimulate respiration, and any increase in the carbon dioxide will stimulate the respiratory system to prevent this. So this is a safeguard to maintain continuous blood flow and to maintain good oxygenation through the golden artery, and this is the golden gate of the golden artery, which is the internal carotid artery. This is a view showing upper border of thyroid cartilage. Bifurcation, as we said, is variable. Here it is slightly above, dividing into the internal carotid and the external carotid. As we said, the internal is the direct continuation of the common carotid artery, and here the external giving the branches, internal carotid artery arising in the neck, and in, as we said, the sternomastoid should be here, and the internal jugular lateral to it, and the vagus is posterior and in the carotid sheath, posterior to them, and the sympathetic chain embedded in the wall. And here is the posterior belly of digastric with the posterior belly of digastric here with the hypoglossal, and here the stylopharyngeus muscle, the stylohyoid muscle with the glossopharyngeal nerve. Another view, as we said, common carotid, internal carotid giving no branches, direct continuation, crossed by a muscle, the posterior belly of digastric, and the nerve, which is the hypoglossal nerve. Above, crossed by a nerve, the glossopharyngeal nerve, and two muscles, the stylopharyngeus and the stylohyoid nerve. Also, here in front of the internal carotid artery, we have the ansa cervicalis. The ansa cervicalis is formed of the descendens cervicalis and the descendens hypoglossae. Descendens cervicalis from C23 and the descendants hypoglossi also from C2, C3, but it is the fibers are present in the hypoglossal nerve, and they unite together, descendants hypoglossi, descendants cervicalis, forming the ansa cervicalis, or the loop, which is supplying the pretracheal muscles. This is another view, cervical carotid. See the origin of the internal carotid. You see the bulge in relation to the external carotid, the carotid sinus, or the carotid bulb, and then you have a small body attached posteriorly called the carotid body. Sometimes you have carotid body tumors. The internal jugular is always lateral to it. And this is another view showing the ansa cervicalis in front of the carotid, and you will see the posterior belly of digastric. You will see the posterior belly of digastric with the hypoglossal nerve. This is another view, and here you see the external carotid artery. Deep is the internal carotid artery, and this is to show you that the internal carotid artery is medial always to the internal jugular vein, except when it enters the neck, it becomes anterior to the internal jugular vein. So before entering the neck, the carotid canal in the petrous bone is anterior to the jugular foramen. So the internal carotid artery is anterior to the internal jugular vein, and you will notice here something amazing. The carotid artery, when entering the petrous bone, is acquiring a sheath, fibrous sheath, which is a dual fold, and it is surrounded by veins before entering the petrous bone, and we will know why. And here is the external carotid dividing into the maxillary artery and the superficial temporal artery in the parotid. Another view, entrance of the neck, internal carotid artery is deep, the internal jugular vein is lateral to it, then it becomes posterior to it, and in between you will have the vagus nerve and its entrance into the petrous bone. Again, as you see, carotid, internal, carotid sinus, and the entrance into the petrous bone. Here is to show you that the distance between the internal and the common carotid and the vertebral artery is not far. You can feel the internal carotid artery against the foramen transverse, against the transverse process of C6, and the vertebral is included in foramina transversalia of C6 and going on. So they are close to each other. Surgical importance of the cervical carotid. In anterior cervical discectomy, the plane, if you want to reach the prevertebral fascia, if you want to reach the anterior surface of the cervical vertebrae, you go medial to the carotid sheath. So the plane is medial to the carotid. When you open the skin, you go in front of the sternomastoid and you start feeling deep to it the carotid pulsation, and you go in the plane medial to this carotid pulsation. The second application is in the surgery for carotid endarterectomy or in cases of balloon dilatation and stenting of the internal carotid artery. So this is an axial view, and to show that in order to reach the prevertebral space, you go anterior to the sternomastoid, you feel the carotid sensation, and you go in the plane medial to the carotid, and then you get the prevertebral fascia. So always keep the carotid and the jugular, of course, lateral to you, and go in the plane medial to it to reach, you can dissect it with your finger to reach the prevertebral fascia and the cervical vertebra. Here is another view, putting the retractors medial to the carotid of this side, and you reach here, you have the trachea and the esophagus, and here you have the sternomastoid and the carotid sheath, and you go in between to reach the cervical vertebrae. This is to show you carotid end arterectomy. You have a plaque at the beginning of the internal carotid, sometimes in the common carotid. You can deal with it by a neurointerventional technique. You introduce a catheter, a very small catheter, that passes through the thrombus, and thrombus is attached to the intima. And then you put a filter, and then you introduce, after that, a balloon, and you inflate the balloon to dilate the origin of the internal carotid artery. With this dilatation, you get debris, and the debris are very dangerous if they pass in the internal carotid, cause distant emboli in the brain. So we put the filter to take it out after we finish the procedure. The second way is to do it open, and you do an arteriotomy according to the level of the thrombus. You know it by the angiography, and you open in the common carotid, internal carotid origin and external carotid, and you take the plaque with the intima, and then you do suturing of the arteriotomy, and you get reflow. We will not discuss all the details, but you should know that the cervical segment is important for carotid end arterectomy. The petrous segment, which is the petrous carotid, as we said, is the part of the carotid inside the petrous temporal bone. It has a vertical segment in front of the cochlea and the tympanic cavity, forming a loop, posterior loop. They call it posterior loop according to the position. It is posterior, and a horizontal segment. So we have the petrous carotid has a vertical segment, horizontal segment. In between them there is a loop called the posterior loop, and it is directed anterior and medial to form the lateral loop medial to the Gasserian ganglion, as we'll see it now. So the carotid is rising in the neck vertical. It continues for a small part in the petrous bone vertical. Then it needs to turn horizontal to reach the cavernous region. So it forms the posterior loop, forming the horizontal segment, and horizontal segment is directed anteriorly because the cavernous sinus is anterior to the petrous bone, and medial because the cavernous sinus is medial to the petrous bone. So vertical, posterior loop, then forms the horizontal segment directed anterior and medial. Why anterior and medial? To reach the cavernous sinus. On its way to reach the cavernous sinus, it forms the lateral loop, as we'll see, medial to the Gasserian ganglion. The vertical segment of the carotid is separated from the cochlear and tympanic cavity by a thin bone lamellae which disappears with age. So the carotid canal has a bony covering that disappears with age, and this bony covering gets thin by continuous pulsations all through the life of the person, and this will make it something very serious, because if you don't have this bone lamellae, what will happen? You might hear all the noise of the internal carotid artery continuously, because the pulsations are really big in the petrous carotid, but we don't hear it. How? The roof of the horizontal segment also, because the carotid petrous is surrounded by a layer of dura or sheath and small veins which reduce the power of the carotid pulsations to protect the cochlea and the tympanic cavity from hearing the carotid. So there is a layer of dura or a sheath around the carotid surrounded by small veins which absorb the carotid pulsations not to reach the cochlea or the tympanic cavity. This is the vertical segment. The roof of the horizontal segment, as we said, makes the posterior loop. Horizontal segment is separated from the Gasserian ganglion also by a thin layer of bone forming the floor of the Gasserian ganglion fossa, which might be deficient. So the carotid artery, as you will see, in relation the horizontal part of the petrous carotid is below and medial to the Gasserian ganglion. Gasserian ganglion is present in the Gasserian fossa, and the carotid above the foramen lacerum is below this Gasserian fossa, as we will see. This is the course of the carotid. I'm saying loops, a lateral loop, posterior loop. Here is, if you imagine that the cervical carotid is here, this is the petrous carotid, vertical segment and horizontal segment, and here the loop, which is the posterior loop. And we said the carotid will go after that medially and will go to reach and upwards to reach the cavernous sinus, and above, it passes above the foramen lacerum, forming the lateral segment, which is forming the lateral loop, as we will see later, and the lateral loop is medial to the trigeminal ganglion or the Gasserian ganglion. Then it passes to reach the cavernous sinus. In the cavernous sinus, we have the medial loop, which is convex posteriorly. The lateral loop is convex outwards, laterally and downwards. Why? Because the artery wants to go upwards and medially. So changing the direction from lateral to medial, from downwards to upwards, the loop has to be directed downwards and laterally. Blood is coming here, changing first change in direction, the posterior loop, then the horizontal segment, then the lateral loop, convex outwards and laterally, then the lateral segment, then the cavernous sinus forming the medial loop, and the intracavernous part, then the anterior loop, which is anterior part of the cavernous sinus and directed anteriorly, and it passes intracranially. We'll repeat it several times, don't worry. Here again, you see the petrous. The internal carotid artery is anterior to the internal jugular vein and anterior to the vagus nerve. Here is the carotid canal in the petrous bone, and posteriorly there is the jugular foramen. And then here it starts C1, here is C2, and then it passes to reach the cavernous sinus. So this is another view showing this is the cervical part of the internal carotid. This is the petrous part of the internal carotid, where you see the petrous loop, the posterior loop of the petrous bone, and then the cavernous part, where you see the medial loop and the anterior loop, and then we have the clinoidal part and the intracranial part. Another view of the petrous carotid, if you are looking anteroposterior and you see the carotid in internal carotid passing into the petrous bone in the carotid canal, and it is from being vertical becomes horizontal, and it passes upwards and medially, forming the lateral loop, which is medial to the Gasserian ganglion, directed downwards and laterally, and then it forms the medial loop, which is directed posteriorly in the cavernous sinus, and the anterior loop directed anteriorly, and then it passes intracranially. Another view, this is the petrous and the lateral loop, cavernous segment, and then passes in the cavernous sinus and medial to third and fourth, as you will see. The petrous carotid from the middle fossa, there is a very important surgical application for this part, so that we have to talk about it from above. We are talking about the petrous bone, talking about the petrous carotid from lateral and from below, but from above we have two important triangles in relation to the greater superficial petrosal nerve. Can you reach the petrous carotid and the lateral carotid from the middle fossa? Yes, we can reach it. And we have a triangle called the posteromedial triangle of Kawasi and the posterolateral triangle of Glasscock's, medial and lateral to the greater superficial petrosal nerve. So if you go through the middle fossa, you elevate the dura of the middle fossa, you will find a nerve, anterior surface of the petrous bone, which is the greater superficial petrosal nerve in its way to the pterygoid canal. And what is medial to the nerve is the posteromedial triangle of Kawasi. What is lateral is the posterolateral triangle of Glasscock. And drilling of the Kawasi triangle is in a posterior direction to expose lesions in the lateral pons and Gasserian ganglion. So Kawasi triangle is the most medial part of the petrous bone, which contains nothing, just thin bone. If you have the skull and you see the petrous bone, you find medially very thin bone, which contains nothing, and some air. This is the Kawasi triangle. And I'll show you now what do you mean by drilling in the posterior direction. In Glasscock triangles, you drill inferiorly to expose the horizontal segment of the petrous carotid if you need proximal carotid control in the cavernous sinus. So this is the petrous carotid from the middle fossa. Let me explain it. This is the left side. This is the dorsum celli, the cella turcica, the anterior clinoid, and this is the petrous bone. And you will look to what the greater superficial petrosal nerve. Here is the foramen ovale, and here is the foramen spinosum. Here is the V3 of the trigeminal, and behind it is the middle meningeal artery, which enters the skull. And you have here, along the anterior surface of the petrous bone, what we call the greater superficial petrosal nerve. So the nerve has got a lateral part and a medial part. So this is the nerve. You remember now, this is anterior, this is posterior, this is medial, and this is lateral. What is medial to the nerve, the part of the petrous bone, is the Kawasi triangle, which is between the greater superficial petrosal nerve, between the superior petrosal sinus, and the Gasserian ganglion. Gasserian ganglion is here, on the petrous apex, trigeminal root, Gasserian ganglion here, and gives V1. It's triangle made by medial to the greater superficial petrosal nerve, between it and the superior petrosal sinus and the Gasserian ganglion, is called the Kawasi triangle. And the triangle lateral to the greater superficial petrosal nerve, which is present posterior to the foramen ovale and the foramen spinosum, greater superficial petrosal nerve, and from area called the arcuate eminence to the middle, to the foramen spinosum, you get the Glasscock triangle. So what you need to know is that from the middle fossa, the petrous and lateral carotids can be exposed through two triangles. One medial triangle of Kawasi, Professor Kawasi, a very famous Japanese neurosurgeon, and from lateral we have the Glasscock's triangle, which is lateral. The Kawasi triangle is drilled in a posterior direction. You remember, if you can imagine what I'm saying now in 3D, you see that the Glasscock triangle is present in the floor of the middle fossa, but the Kawasi triangle is present in the anterior surface of the petrous bone. So this is the junction between the floor and the anterior surface of the petrous bone. If you want to expose Glasscock triangle, you drill in a downward direction. What would you have here? You will have the carotid artery, the lateral carotid artery, the horizontal segment of the petrous carotid artery, and you can use it to have proximal control instead of opening in the neck if you want to do something lateral to it. So this is the, if you want to do something in the internal carotid artery, distal to it. And this is where you can expose the carotid. And the cavasi contains nothing but air and bone, and you can expose the lateral pons. You see here the sella, this is the dorsum sellae, and this is the foramen magnum. Here is the brain stem, here is the pons. You can expose the lateral pons. If you remove this cavasi triangle, you can expose the lateral pons and the origin of the trigeminal root from the lateral pons. Again, this is the right side, and this is the, the geniculate ganglion of the facial. You have the directions, lead books down. It goes from the internal auditory canal laterally, then backwards and downwards. When it changes its direction from laterally to backwards, we have the geniculate ganglion, and from it we have the greater superficial petrosal nerve on its way to the pterygoid canal. And what is medial to the greater superficial petrosal nerve is cavasi triangle, and what is lateral to the greater superficial petrosal nerve is the Glasscock's triangle. This is cavasi triangle. You drill in the posterior direction. This is the Glasscock's triangle. You drill in an inferior direction. Here you can expose the internal carotid artery. Here you enter the lateral pons. And the cavasi, as we said before, is triangle between the greater superficial petrosal nerve, between the superior petrosal sinus, and between the Gasserian ganglion. The Glasscock's triangle is between the greater superficial petrosal nerve and the arcuate eminence with the middle meningeal, and the middle meningeal with the greater superficial. You get the Glasscock's triangle. This is from the middle fossa view of the petrous and laceral carotid artery. Another view showing this is the horizontal segment of the petrous carotid. If you drill in this inferior direction, you drill Glasscock's triangle, which is exposing the internal carotid artery. And if you expose more medial, you get the cavasi triangle exposing the middle fossa. Of course, this is the trigeminal ganglion cut, trigeminal root, and taken laterally to expose the carotid here, which is the lateral loop of the carotid. The lateral segments, again, cervical carotid, vertical segment, petrous, posterior loop, horizontal segment, lateral loop, medial to the Gasserian ganglion, then it passes the lateral segments, reaching the cavernous sinus, the medial loop convex posteriorly, then the cavernous carotid, then the anterior loop convex anteriorly. So now we are going to talk about this part after the petrous carotid became horizontal, and as we said, it needs to go upwards and medially to reach the cavernous sinus, because the cavernous sinus is above and medial to the petrous bone. So the carotid has to take its journey to make a loop, to go medially and to go up. So the loop will be directed down and laterally. Very logical. The lateral segment. Lateral segment is a short segment that begins above the foramen lacerum and ends at the petrolingual or petrous phenoid ligament, as we'll see it now. It forms, as we said, the lateral loop, medial to the Gasserian ganglion, convex downwards and laterally, and the artery ascends upwards and medially to reach the cavernous sinus. As we said, the artery is passing upwards and medially, so it has to make a loop directed downwards and laterally. It is considered extradural, surrounded by cartilage and fibrous tissue. So up to here we consider the carotid did not pierce the dura, did not reach the cavernous sinus. Lateral segment is an extradural segment surrounded by cartilage and fibrous tissue. Carotid artery does not pass through the foramen lacerum. Please pay very good attention, everybody, because some believe that the foramen lacerum passes through it the carotid? No. It contains the cartilage, and nothing passes through the foramen lacerum, maybe sometimes an emissary vein, but the carotid is above the foramen lacerum, and it does not pass through the foramen lacerum. As we said, and here we'll find the lateral loop. To see the lateral loop, you have to take out the Gasserian ganglion, to cut it and see it. It is medial to it. Or you can imagine it. This is the lateral segment from the horizontal segment of the petrous carotid, horizontal, petrous internal carotid artery going medially, and this is the lateral loop, convex downwards and laterally. After that, it makes the medial loop convex posteriorly, cavernous part, and the anterior loop convex anteriorly. Another, if you can imagine, this is from the left side, this is medial, and this is lateral, and this is the left cavernous sinus, and here is the V1 in the cavernous sinus, V2 in the foramen rotundum, and V3 in the foramen ovale, and the middle meningeal in the foramen spinosa. And if you can imagine that the vertical segment became horizontal, then the horizontal segment wants to go upwards and medially. So it forms a loop which is convex outwards and laterally. If you can imagine the loop here, you see, this is the loop. If you make it by drawing, this is the loop. Horizontal segment, and then the lateral loop, convex downwards and laterally, and then it passes to reach the medial loop inside the cavernous sinus. So this is without the drawing, and this is after. Again, this is a very nice view of the internal carotid. This is the left side, and this is the carotid intracranial. This is the ophthalmic division, and we are on the left side, and then here it forms the medial loop, cavernous part, and here is the medial loop and the anterior loop. Here is the medial loop. Here is the petrous carotid again, the horizontal segment of the petrous carotid. It forms here the lateral loop. Of course, you don't see it because the trigeminal is covering it. But if you remove the trigeminal, you'll find that there is a loop, convex downwards and outwards, and then this loop enters the cavernous sinus, forming the medial loop. Why it is medial? Because this one is lateral, but it is convex posteriorly. Then the cavernous, then the anterior loop of the cavernous, then it pierces the dura and enters intracranially, and here is the ophthalmic artery. Another view, here, horizontal part of petrous carotid, lateral loop, medial to the trigeminal, then the medial loop in the cavernous sinus, convex posteriorly, and then cavernous part, and then the ophthalmic segment. And if you see here, this is the geniculate ganglion, and this is the greater superficial petrosal nerve. If you drill in this area downwards, you will get the internal carotid as you see it, but if you drill posteriorly in the anterior surface of the petrous bone, you will get the lateral brainstem. This is the foramen magnum here. Brainstem should be here, and you get, this is Kawasi triangle, and this is Blaskow's triangle. Surgical importance of the lateral segment. In percutaneous procedures for trigeminal neuralgia, whether injection of glycerol, whether balloon inflation, whether radiofrequency, the carotid might be injured, being medial to and inferior to the ganglion. So, in trigeminal neuralgia, we enter through a certain point called Hartel's point. We discussed this before, and you pass your needle through the foramen ovale to inject into the Gasserian ganglion or do radiofrequency. And here, always remember that the lateral loop of the internal carotid is medial to the Gasserian ganglion. If you go too much medially with your needle, you might injure the internal carotid artery. The needle is coming from the foramen ovale, into the Gasserian ganglion, but if you go in a medial direction, you might injure the lateral loop medial to the Gasserian ganglion. Cavernous segment, it extends, as we said, from the petrolingual ligament to the proximal dural ring, inferior and medial to the anterior clinoid. Don't panic, we will explain this very easily, it's very simple, but you know that the cavernous sinus is entered by the carotid through ligament called the petrolingual ligament, and it passes in the cavernous sinus until it exits through the dural ring. It has, as we said, the medial loop convex posteriorly, horizontal segment, as we saw before, and the part of the loop convex anteriorly. It is inside the cavernous sinus with the sixth nerve, lateral to it, surrounded by sympathetic plexus, so the carotid artery is present inside the cavernous sinus with the sixth nerve. But the trochlear, the oculomotor, the trochlear, and V1 are present in the lateral wall, but the cavernous sinus, cavernous carotid artery, and the sixth nerve pass inside the cavernous sinus with a sympathetic plexus around the carotid cavernous, what we call the deep petrosal nerve, as we'll see. And the carotid in the cavernous sinus is medial, as we said, to the third, fourth, and V1, which pass in the lateral wall of the cavernous sinus. And in the cavernous segment, it gives many branches. So let's see again where we are now. Vertical, posterior loop, horizontal part, lateral loop, lateral segment. Then it passes into the petrous sphenoid or petrolingual ligaments. Then it enters the cavernous sinus. We'll talk about the medial loop. We'll talk about horizontal part and the anterior loop. We talk about the dural ring. Here, to enter the cavernous sinus, it passes through the petrosphenoid ligament or petrolingual ligament. Lingula is a part of the sphenoid bone, forming medial and lateral petrosphenoidal ligaments, medial and lateral petrolingual ligaments, fixing the carotid in place. And distally it passes through the ring, also fixing the carotid in place. So you see here to show you that the carotid is pulsating. It's a giant artery and it has giant pulsations. If it is left unfixed, the pulsations will do damage to all the surrounding structures, and the artery will be like a fish playing, going and up and down and changing its direction with the pulsation. So it has to be fixed. Very good fixing process, which is ligamentous fixing, what we call here the proximal ring, which is the medial and lateral sphenopetrosal ligaments or petrolingual ligaments, fixing the carotid in place, and then before coming up, it is fixed again by the proximal and the distal dural rings. So we have a proximal dural ring and we have a distal dural ring. The distal dural ring has two rings, the proximal distal dural ring and the distal dural ring, not to mix them up. Please, I'll say it again, don't mix them up. We have a proximal ring, which is a single ring. We have a distal ring, which is two rings actually, a proximal one and a distal one. So we call this the proximal ring. We call this also the proximal ring. But we call it the proximal part of the distal ring and the distal part of the distal ring. And there is a space between these two rings, which is the clinoidal carotid, which is medial to the anterior clinoid process. And the value of these rings to fix the internal carotid artery in place with this giant pulsation, it does not move. Again, this is the medial loop, convex posteriorly. This is a branch, we'll see the name of the branch later, horizontal part, and this is the anterior loop, and this is the dural ring. So here there is a ring which is the proximal dural ring, and here we have two rings, the proximal distal ring and the distal ring, and it pierces the distal ring, entering intracranially. You see, this is the intracranial carotid artery, and we are here on the right side. Again, this is the V1, the V2, and the V3, and we have medial to the V1 the lateral loop, then it goes upwards and medially, passing into the cavernous sinus. When it reaches the cavernous sinus, it wants to go anteriorly, so the loop is posterior. After reaching the cavernous sinus, where is it going to continue? It cannot go upwards like that. It goes anteriorly, so the medial loop is convex posteriorly, and then it goes upwards, so the anterior loop is convex anteriorly, and then it comes up. This is a view of the distal ring, and we said we have two distal rings, a proximal distal ring and a distal ring. This is ligamentous and this is dural. This is extending from the anterior clinoid to the middle clinoid. What is the middle clinoid? It is the most lateral part of the tuberculum cell. This ligament can be calcified. If you see some skulls, if you remember, you see an optic foramen and then another foramen below it. The second foramen below it is nothing but the calcified proximal part of the proximal ring, extending from the anterior clinoid to the middle clinoid. And here is the dural ring, which is the distal ring, and in between there is the anterior clinoid process. And if you see medially, you see the carotid, seen here extradurally, called the clinoidal carotid artery. Clinoidal segment, C5, extends from the proximal to the distal ring, as you said. It is extradural and extends from the proximal to the distal dural ring. So the clinoidal segment is present between the two rings, and it is extradural and it is medial to the anterior clinoid process. Again, we are talking about this part. This is the distal ring. This is the clinoidal part. Again, here is the left side, the left optic, the left carotid intracranial, the ophthalmic. Here is the cavernous sinus. What we'll see here, this is the carotid, forming the anterior loop of the carotid, and this is the oculomotor and the trochlear. And we remove the anterior clinoid. We see a part of the carotid here, which is the clinoidal part, which is medial to the anterior clinoid, which was removed, and which is between the two rings of the two parts of the distal ring, the proximal part and the distal part. And the anterior loop is directed anteriorly because it does not want to continue in the orbit. The artery has to go intracranially, so it shifts to go up. So the loop is directed anteriorly. Can I understand it now? Another view showing the proximal part of the distal ring and the distal part of the distal ring, and here the anterior clinoid, it is medial to the anterior clinoid. And here is the anterior loop of the internal carotid, medial to the anterior clinoid. Between the two rings is the clinoidal segment of the internal carotid, and the anterior loop is here, part of it intracavernous and part going intracranial now. Between the two rings, medial to the anterior clinoid, is the clinoidal loop. Ophthalmic segment, now we are starting to go intracranially. We have two segments intracranially. Extends from the distal ring as a continuation of the clinoidal to the origin of the pecum. It is intrarachnoidal. It is below and lateral to the optic nerve. Most of you know this relation, the optico-carotid triangle. It gives two branches, the ophthalmic and the superior hypophyseal arteries, as we'll see. So now we are talking, we entered the cranium. This is the segment, the ophthalmic artery is here, and here is starting the ophthalmic segment. Ophthalmic segment is in blue. From when the carotid artery pierces the dura, pierces the distal part, the distal dural ring, and passes intracranially until the origin of the posterior communicating. This blue part is the ophthalmic part of the intracranial internal carotid, and here is also the ophthalmic part, and here is the ophthalmic segment, distal ring pierced, entering intracranially. This is the cavernous carotid. We have the ophthalmic, and here is the ophthalmic segment till the origin of the PCOM. View from above, the ring surrounding the carotid, ophthalmic artery arising here, and superior hypophyseal artery should be arising here. Another view from above, ophthalmic artery, under cover. We took out the optic nerve on the right side because it is under the optic nerve, reaching the PCOM. Between the ophthalmic artery and the PCOM, this is the ophthalmic segment, giving the ophthalmic artery, and here the superior hypophyseal artery. Again, this segment is very important. It is the optico-carotid triangle, is an angle to work. You know that if you have a terional approach, frontotemporal approach, you can go, the pathways, the corridors are through the interoptic, prechiasmatic space, or through the lamina terminalis, or through the optico-carotid triangle, or lateral to the carotid. So what is lateral to the carotid is the ophthalmic segment of the internal carotid artery. What is lateral to the optic, is the ophthalmic segment of the internal carotid artery. And here you see this is lateral view, left side, edge of the tent, what we call here the anterior incisural space. This is the optic nerve, and this is the carotid, and this is the PCOM. Between the entrance to the PCOM is the ophthalmic segment, and this is the superior hypophyseal branch of the carotid artery. Again, carotid, optic, optic-carotid triangle, PCOM, ophthalmic, segment in between, ophthalmic segment, carotid. Most of the cases, the ophthalmic artery arises after the carotid leaves the canal, the dural ring, not in the cavernous sinus, but in 6% it can arise from inside the cavernous sinus. And you see here always the superior hypophyseal artery. It is the only medial branch of the internal carotid artery. Remember this. When the carotid artery pierces the dural ring entering intracranially, it gives immediately the ophthalmic and the superior hypophyseal. Ophthalmic artery anteriorly, under cover of the optic nerve, superior hypophyseal artery medial. It is the only medial branch of the carotid artery. Again, the segments, cervical, the petrous, the lacerum, the cervical, yes, the petrous, and this is the lateral, and this is the cavernous, the clinoidal, the ophthalmic, and the communicating. Surgical importance of the ophthalmic segment, aneurysms. It is the site of a very famous aneurysm called carotid ophthalmic aneurysm, under cover of the optic nerve, and the neck might be present in the cavernous sinus. In this case, we need to open the cavernous sinus by opening the distal dural ring. And it is the site of superior hypophyseal artery aneurysm, which is the only branch medial to the carotid. So when you have an aneurysm medial to the carotid, it is a superior hypophyseal artery aneurysm. This is to show you superior hypophyseal artery aneurysm is medial to this is the ophthalmic artery anterior. This is superior hypophyseal from the medial. This is the right side. This is the ophthalmic artery. This is superior hypophyseal artery. If the aneurysm is medial to the carotid, it is superior hypophyseal. If it is anterior to the carotid, it is an ophthalmic. Communicating segment from the PCOM to the bifurcation. The last segment from posterior communicating to carotid bifurcation into the anterior and medial cerebral arteries present under the anterior perforated substance. It passes between the optic nerve and the oculomotor nerve, and it gives two branches, posterior communicating artery and the anterior choroidal arteries. So when we reach the PCOM, this is the carotid artery, a very big carotid. This is the posterior communicating artery. From the posterior communicating artery to the carotid bifurcation into A1 and M1, this segment is called the communicating segment. It gives the PCOM and the anterior choroidal arteries. This is from the right side. This is the right optic, right carotid dural ring, and this is the communicating segment of the internal carotid artery. Another view showing the communicating segment, the PCOM, distal to the PCOM, we get the anterior choroidal artery. Surgical importance of C7, as C6, site of common aneurysm, the PCOM and the posterior communicating artery aneurysm, and less common anterior choroidal aneurysm. Both can be clipped or coiled. The PCOM is common associated with third nerve palsy. Most of the cases, you get third nerve with the PCOM aneurysm. And retraction, if you want to expose it, is on the frontal lobe, because the PCOM aneurysm is mostly adherent to the medial surface of the temporal lobe. These are surgical details we are not going to discuss in detail, but you should know that the PCOM aneurysm can produce third nerve, and the PCOM aneurysm is closely related to the temporal lobe. So if you want to expose it, retract on the frontal lobe. Proximal control of the carotid is a must before clipping. And here is to show you the internal carotid artery. This is the left side, the optic nerve, optic chiasm, internal carotid, opticocarotid triangle, and the posterior communicating artery aneurysm directed laterally or posterolaterally. Remember, the only medial is superior hypophyseal. Another view at the origin of the PCOM, and you get the aneurysm. You get some perforators on the neck of the aneurysm. This is posterior communicating, and this is the aneurysm. Another view showing the PCOM aneurysm in a true angiography in the communicating segment of the internal carotid, the posterior communicating artery aneurysm. Another case you find this, the aneurysm, posterior communicating artery,